Menisci are pieces of fibrocartilage that are located on the articular surface of the tibia. The majority of the cartilage is composed of type 1 collagen and is arranged in a circumferential pattern to endure the forces of weight bearing. Their purpose is to allow for cushioning between the tibia and femur, which increases contact area during load bearing, protect against compressive and rotational forces by providing joint stabilization, and lubricate the joint, articular cartilage nutrition, and proprioception. They are wedge-shaped in the sagittal plane, which means they are thicker in the periphery and thinner centrally. They are aneural, which means they have no nerve innervation. There are 3 vascularity zones: the red zone, which has good vascularity, the red-white zone, which has moderate vascularity, and the white zone, which has no vascularity at all. The outer third of the meniscus has a blood supply, while the inner portion does not. The ability of the meniscus to heal on its own is directly related to the portion torn due to the level of vascularity. Blood supply is mandatory to promote healing. The menisci are connected to each other by the transverse meniscal ligament.
The medial meniscus. The medial meniscus is C-shaped and is more broad posteriorly than anteriorly. It is more commonly torn because it is anchored firmly to the tibial plateau. It attaches to the deep portion of the MCL and the knee capsule. It has less tibial coverage, which increases contact area, and it transmits 50% of the joint load.
The lateral meniscus is crescent-shaped and is smaller and more mobile than the medial meniscus. Since it's less attached to the tibia, it is also less prone to injury. It covers more tibial area, which decreases the contact area. It also transmits 70% of the joint load.
Meniscus lesion facts. Meniscal injuries comprise approximately 12 to 14% of knee injuries. Men are more prone to these injuries than women. Men receive about 81%, while women sustain about 19% of these injuries. Approximately half of the patients with meniscal injuries are between the ages of 20 to 29. Meniscal lesions are also more prevalent in the right knee, with about 56.5% occurring in the right knee compared to the left. Medial meniscus lesions are the second most common knee injury after torn ACLs. About 10.76% of knee injuries are medial meniscus injuries, and approximately 24% of meniscus tears are of the medial meniscus. About 3.66% of knee injuries are lateral meniscus injuries, and approximately 8% of meniscus tears are of the lateral meniscus. Thus, the ratio of lateral meniscus lesions to medial meniscus lesions is 1 to 3.
Meniscus lesions usually occur from non-contact trauma. They commonly occur during a quick change in direction, like with cutting or while decelerating. For this reason, these injuries are frequently seen in soccer and skiing. Additionally, lateral menisci tears are associated with gymnastics and dancing, while medial meniscal tears are associated with tennis and jogging.
Diagnosis of meniscal tear. The patient will complain of pain within either medial or lateral joint line. Pain will likely occur with extension. They are also likely to have felt a pop at the time of injury. They may experience a locking or giving way sensation with extension as well. A positive McMurray's and Apley's test support a torn meniscus diagnosis. Symptoms other than pain include swelling and stiffness. Since MRI shows soft tissue, they will be able to detect a meniscus tear with 64 to 95% accuracy. The test has a sensitivity of 88% and a specificity of 57%. The tear will show up in white on the MRI.
Lesion classifications. A complete tear is a tear that is tore all the way through the thickness of the meniscus. while an incomplete tear or a flap tear is a smaller tear which is still attached. A flap tear is a tear in an oblique vertical cleavage producing a flap, or what is also known as a parrot beak. A radial tear is a horizontal tear on the inside of the white zone. A tear known as the parrot's beak usually occurs with previous trauma or a popliteal cyst pathology. Meanwhile, a bucket handle tear is the tearing of the entire longitudinal segment and is displaced medially towards the center of the tibia. This leads to locking at about 10 degrees of flexion. A longitudinal tear occurs with twisting A longitudinal tear occurs with a twisting motion when the foot is fixed. This causes compression and torsion. A horizontal tear is a result of degeneration, and it can cause locking and instability of the knee.
Treatment approaches. Meniscus tears can be treated conservatively or surgically. The goal is to try to preserve as much of the meniscus as possible. Conservative treatment of rice and anti-inflammatories can be applied for tears occurring in the vascular zone. This treatment should be done for about 6 weeks to see if healing will occur, and if not, an arthroscopic meniscectomy becomes a consideration. The 3 main goals of surgery are to reduce pain, restore function, and prevent osteoarthritis. The popular surgical options are either repair or meniscectomy. A meniscectomy can be total or partial. More on repair. Repair is when you use sutures to repair the torn aspect. It has a longer recovery time but decreases the amount of long-term degeneration contributing to osteoarthritis. Longitudinal and peripheral tears within the zone of vascularity generally have a greater healing capacity and thus are great candidates for repair. Meniscectomy is the removal of cartilage. A total meniscectomy is when the entire meniscus is removed. This is used more widely for those with a degenerative tear. Partial meniscectomy is when the torn segment of the meniscus is removed. This is preferred since the outer vascular edges of the meniscus are left to contribute to post-operative healing and to maintain biomechanical function. Approximately 61 out of 100,000 meniscus patients end up having a meniscectomy. Arthroscopic meniscectomies have good short-term results and usually take 15 to 30 minutes to perform. Partial meniscectomies are especially ideal for bucket handle and flap tears. A meniscus repair is preferred to meniscectomy when possible, as meniscus-deficient knees are at a significantly increased risk of developing OA and also contribute to increased instability. OA is the most common surgical complication. On the other hand, the study by Rockborn et al. Did not see a clinically significant difference in the number of patients who developed OA when the repair and meniscectomy groups were compared. Only 7% more, 57 to 50% of meniscectomy patients were found to have developed OA compared to the repair patients. This could be attributed to their athleticism and fitness levels prior to surgery, which could be decreasing their rate of sustaining OA. According to a long-term study by Kim et al., meniscectomy decreases knee function. The study by Anderson Molina et al. Found more long-term radiographic changes in total meniscectomy patients than partial meniscectomy patients. After this 14-year study, 28% of the partial meniscectomy patients experienced a joint space reduction, while 33% of the total meniscectomy patients experienced a joint space reduction. The narrowing of the joint space has been found to be a more clinically significant long-term post-meniscectomy decrement than loss of knee function. Rockborn et al. Found that less stress was absorbed by the menisci after a partial meniscectomy than after a total meniscectomy. Osteophytes on the femoral condyles and femoral condyle squaring were also long-term radiographic effects of meniscectomy. No clinically significant differences were found at the 13-year follow-up between repair and meniscectomy groups in regards to range of motion, muscular strength, and joint alignment. Partial meniscectomy is preferred over total meniscectomy because of less biomechanical disruption, but both procedures have a negative impact on biomechanical functions. Rehabilitation techniques. There are guidelines for rehab, but overall, rehabilitation must remain individualized based on the lesion classification, type of surgery, so repair versus meniscectomy, or current symptoms. Menisectomy post-operative rehab is rapid and aggressive when compared to that of a repair. The day after the menisectomy, full weight-bearing range of motion exercises, quad sets, and straight leg races are permitted. Closed chain exercises are also allowed if there is no knee pain. Within 1 week, these patients are able to walk on their own. Running is typically allowed 4 to 6 weeks after surgery. Team participation typically occurs 6 to 8 weeks out. In contrast, repair patients don't walk on their own for about 5 to 8 weeks. Running doesn't occur until 12 to 16 weeks out. Team participation takes effect around or after week 20. Hence, many young athletes want a meniscectomy in order to be able to return to play sooner, but the costs of long-term decrements and benefits must be weighed accordingly.